Good afternoon, everyone. Welcome to our educational info webinar this afternoon. My name is Gabriele Colasurdo. I'm the Manager of Education and Patient Services at Myeloma Canada. Today, our presentation is going to be on key research updates from the 2021 International Myeloma Workshop, which happened, I believe, a few months ago, a month or two ago in the summer. Before I introduce you to our presenter, I will just go over just a few things. So the first thing, I'd like to thank our sponsors. So without the help of our sponsors, it'd be hard to do these webinars. So thank you to Amgen, Binding Site, BMS, Janssen, Takeda, and Sanofi Genzyme. As many of you know, all of our webinars are recorded and they're put onto our YouTube channel. So how do you access a recording? You're going to get a lot of information today. And so if you want to go back and, kind of review the information and just if you missed something, then you go to youtube.com, you type in Myeloma Canada. You could also do it from the YouTube app on your phone. Just type in Myeloma Canada. You'll find our channel. You can subscribe when you hit the red button, and once you hit on the red button, there's a little bell icon. If you click on that bell icon, it'll give you a little notification every time we put a new video up. So that's a good way to keep keep updated on any new videos or any new information that we post on the channel. You could also get there from our website, so myeloma.ca. You hit the resources button right there. It'll open up a menu, educational videos, and that'll simply just send you off to our YouTube channel like I showed you previously. Lastly, how do you ask questions? So we're going to start off with the presentation, and after the presentation, we'll take questions, we'll fill questions, and we'll have a discussion about the topics that you're interested in. So to do that, you type in the question in the box. If you're on your phone and you have the GoToWebinar app, it's the same concept. You click on the questions button, you type in the question, you press the send button. I'm going to receive all the questions, and at the end, I'm going to ask our presenter to answer them. So without further ado, I'd like to introduce you to Dr. Ghulam Manni Mohyuddin, who is a hematologist at the Huntsman Cancer Institute and assistant professor at the University of Utah School of Medicine in Salt Lake City. Dr. Mohyuddin, I hope I'm pronouncing it right. Thank you so much for taking the time this afternoon to present to us.
Yeah, thank you. The pleasure is mine. Just want to make sure I can control the slides. Okay, perfect. Well, thank you again. It's my honor and pleasure to be here. I am going to talk about some important updates from the International Myeloma Workshop. I have intentionally left a lot of time for questions. So hopefully I'll wrap this up in 20, 25 minutes, and then we'll have ample time to go over questions, some of the important themes being discussed at this workshop and in myeloma in general. So yeah, let's get started. So I don't have any conflicts of interest financially to declare. I will say that, I definitely tend to lean more towards clinical studies. So a lot of what you're going to see today are clinical studies. And I think that's often, what patients feel like is directly applicable to them. There's a lot of exciting lab work and basic science updates and new pathways being discovered, but that's not going to be the focus of today's conversation. So I'm going to start by talking about newly diagnosed myeloma. Then we'll talk a little bit about relapse refractory myeloma. Then a few other studies that don't really pertain to newly diagnosed or relapse refractory per se, but were really like thought-provoking and potentially practice-changing concepts. And then there'll be a lot of time, as I mentioned, for discussion. All right, so let's get started. So, there's a trial called the MASTER trial, right? So all of you have heard about MRD, which is measurable residual disease, right? It's a very sensitive marker of how much disease is left, right? As compared to the traditional criteria that we look at, the kappa lambda light chain or, the serum M protein, the assessing for measurable residual disease, whatever assay you use, detects much smaller quantities of disease. So it's been around for quite a few years, but I think only now are we beginning to design trials and have information from trials in which we can actually use MRD to guide practice. So I find this study very exciting because generally, as you all are quite aware, treatment for myeloma is continuous, right? You get diagnosed, you get put on treatment, and then treatment stays for as long as it's working, which can be years and years and years. So what this concept is that patients get a finite amount of treatment, and then if they have achieved MRD negativity, so if they're in a really, really deep response, they can be taken off treatment and just be measured for their MRD. So it's a very small study with 81 patients, but as a proof of concept, it is very exciting because you can this might be what the future of myeloma will look like, right? That you will get short periods of treatment, perhaps 4 to 6 months of treatment, then a transplant. And if you're MRD negative, then you're off treatment and you're watched until or if the disease comes back. So that is the concept of the study, which I find very exciting, which I wanted to highlight to you all. So in this study, as you can see, so if you look at the top right, and you can see that even in patients with high risk, so I guess let's first start by looking at the top left. So you can see that 80% of patients achieved MRD negativity and were able to be taken off treatment. And we don't have long-term follow-up, so we don't know over time how many of these patients, their disease is going to come back and how that's going to be treated. But it's very exciting to be able to say to your patients, I'm going to give you this for a short period of time and then take you off. And as you can see, as you move from the left of the screen to the right of the screen, you can see that even patients with high risk features, right? So if the chromosomes were, they had those characteristic features, what we call high risk, even with those high risk features, patients were still achieving MRD negativity. And in this particular trial, they're using a 4-drug combination. So that's daratumumab, carfilzomib, lenalidomide, and dexamethasone. So it tells you a little bit about the power of these contemporary novel 4-drug regimens to sort of drive the disease in a deep remission. So again, these results are far from definitive, right? It's a small study, it's not randomized, we don't even have long follow-up yet, but I think it highlights a proof of concept and tells you what the future might look like. Short periods of treatment and treatment adapted to response. So if you're responding really well, you get taken off, as opposed to the current standard where everybody gets a specific type of treatment and that stays continuously for as long as it's working, as long as it's tolerated. So that's the exciting part. Now, the other exciting update that I wanted to bring to you all is the Maya study. So you all may or may not have heard about the Maya study, but it's a randomized phase 3 trial, and it compares a 3-drug combination, which is daratumumab, lenalidomide, and dexamethasone, to a 2-drug combination, lenalidomide and dexamethasone. All right, this is one of many 3 versus 2 trials, and they started recruiting several years ago, but only now we're getting overall survival results from this study. So patients in this trial, patients were on either DRD or RD until progression. We already knew that this regimen was efficacious. We already had results for progression-free survival, which means that it delayed progression. But now we have results that show that this study, that this regimen actually makes people live longer, and that's the most important thing for us, right? Coming up with regimens that make our patients live longer and better. So we already knew. So as you can see, the purple graph is daratumumab, Revlimid dex. Compared to Revlimid dex, you can see that there is a clear demarcation between the graphs, and patients receiving daratumumab, Revlimid, dexamethasone, even at 5 years, more than half of the patients had not yet progressed. All right. So this is a trial that's recruiting elderly, non-transplant eligible patients. So you have people in their 70s, and you're giving them 5 years on average without progression. So that is an improvement from previous regimens, and this is a step forward. And daratumumab improves overall survival as well. As you can see, there is a demarcation here between the purple line DRD and then the yellow line RD. So daratumumab, helps when used as part of a triplet for transplant ineligible elderly patients. It prolongs survival as well. So a lot of you, the first question that comes to your mind, okay, we have DRD, we see these results, but it's being compared to Revlimid dexamethasone, not to Velcade Revlimid dexamethasone. I think that's a great question, and I think that it's tough to compare this to VRD. All right, This trial that studied VRD is on the left side here, it's SWOG 077. As you can see here, that the median age for that trial is 63. The median age for the Maya trial, which I just showed to you, is 73. All right. So this study that I just showed you is actually more representative of an older patient population. But the other thing is that in the BRD trial, people did not get treatment continuously. So, in this trial that I showed you, if you were put on daratumumab, Revlimid, dexamethasone, you got the same treatment for years upon years upon years, right? Whereas in the older study of VRD, Velcade was dropped after about 8 cycles. So it's not fair to directly compare, continuous treatment versus de-escalated treatment. But one of the things that I really struggle, and I'm sure some of you can relate to this far better than I can, is neuropathy, right? With VRD, the risk of neuropathy is real. So I am excited about this particular regimen because, there's data that we can use it in elderly patients, and it doesn't have the risk of neuropathy that the use of Velcade or bortezomib does. So I've been in contact with some of the doctors from Canada. I don't think that this is yet approved in Canada for first line, but I think if and when it does, I think it's a good first line option that can be utilized with good now long-term data that it helps people live longer. So that was the Maya study. Now, again, this is a pretty busy slide, but I'm going to try to simplify it for you. So, we spoke about BRD and we spoke about DRD, right? We spoke about DRD, daratumumab, Revlimid, dex for non-transplant eligible patients. But if you're younger, if you're fit, transplant is a valid standard of care option for you. So how can we optimize, regimens for patients that are going to undergo transplant? So this is a European study, and in this, patients younger than the age of 65 were initially randomized to one of 3 different regimens. So again, none of this is VRD, all right? It's carfilzomib, Revlimid, dexamethasone in one arm, followed by a transplant. In the other arm, it's carfilzomib, Revlimid, dexamethasone, followed by just additional carfilzomib, Revlimid, dexamethasone, no transplant. And in another trial, in another arm, it's Cytokine, carfilzomib, and then dexamethasone. So again, VRD is not being compared, but the only reason why I sort of brought this up is that it sort of plays into what is the ideal maintenance strategy. So as you all may or may not be aware, so for newly diagnosed myeloma, for patients who undergo transplant, we initially give induction treatment, then we do a transplant, and then we recommend maintenance, right? The standard of care generally is Revlimid maintenance or lenalidomide maintenance. Now, for patients with high risk features, right? So high risk features means that there's some classical cytogenetic or fish abnormalities, right? They have classical fish abnormalities that we know put them at a high risk for disease relapse. So we know that if these patients are given a transplant and then are put just on Revlimid maintenance, they relapse quicker than patients without high risk cytogenetic abnormalities. So this trial represents that in this trial, patients who got maintenance with carfilzomib and Revlimid did better in terms of progression-free survival compared to patients who got just Revlimid maintenance. So by progression-free survival, I mean, it kept their disease away for longer. So their remission after a transplant was longer if they were using carfilzomib and Revlimid for maintenance. So you can see that the difference is present both in standard risk patients and in high risk patients. I am much more excited about the high risk graph here because the high risk population is something where a lot of our newer developments haven't really translated into a lot of meaningful change for them, right? The outcomes have been getting better and better for standard risk, but not so much for high risk. So I think this represents a step forward for patients with high risk. And I think for those patients, consideration can be made and should be made that after they undergo a transplant, perhaps we should do more than just Revlimid maintenance for them. And I understand that, in Canada, it's a little complicated with reimbursement decisions and all, but at least in the US, I think most myeloma doctors for high-risk disease would consider maintenance with carfilzomib and Revlimid, or Revlimid and Velcade, or Revlimid and another drug, or put patients on a good clinical trial looking at that. So when it comes to relapse refractory disease, there was an update from the OCEAN trial. All right. Now, I think that we are making, I want to start by saying we're making a lot of progress in myeloma, but not every drug is going to succeed, right? And I think it's important for us to sort of disassociate from hype. And if something doesn't work, I think it's also important for us to highlight that. And I think that that's something we all can be more responsible at, highlighting failures and not sort of sugarcoating them. So this is one example where, melflufen dexamethasone was compared to pomalidomide dexamethasone for patients with relapsed refractory disease. All right. Now, this trial at the time it started recruiting, pomalidomide dexamethasone, PomDex, was an appropriate control arm. But I think for today, if someone is a fit patient, they really shouldn't be getting just Pom and Dex, right? You want to get 3 drugs because we know that 3 drugs generally are better than 2 drugs. So we're hearing a lot of, information about subgroups. Generally speaking, what I kind of want to emphasize to you, so there are 2 graphs here, okay? So if you look at the right graph, in people who have had a prior transplant, you can see that the red line, which is actually pomalidomide and dexamethasone, did much better than the blue line, which is melflufen and dexamethasone, right? There's a clear difference between the 2 graphs, all right? So the control arm did much better than the intervention arm. And if you can see in patients who did not have a prior stem cell transplant on the left side, the graphs are more or less overlapping, right? I mean, you can see that maybe the blue line of melflufen and dex did better than the red line of pom and dex, right? But the thing is that it's always tricky, and I brought this up because I want to emphasize this, because there's often a lot of hype and in how we report it. The important thing to mention is that this wasn't how the study was planned. The study wasn't planned to compare people who had a prior transplant versus people who did not have a prior transplant. They got the results, and the results were negative, or if anything, harmful for survival. And then they looked back and they came up with, having had a prior transplant made a difference. So I think in this case, the right way to do things is to sort of design further studies and see if what you're capturing here, is that actually real, or is that just a fluke or statistical noise? And I think until we get further results, I would be very hesitant using this drug, especially when we have other options in this space for relapse refractory disease. So, so CAR-T, which is chimeric antigen receptor therapy, very exciting. We're taking patients' own immune cells, modulating them, teaching them to recognize certain receptors on the myeloma cells and giving them back. The thing is that as compared to lymphoma, where some people get cured, unfortunately in myeloma, with our current CAR-T technologies, people still relapse. So the one regimen that is approved or the one drug that is approved in the United States is a drug called Ide-cel or Abecma. And on average, you get about 8 to 10 months of remission, which that's an important step forward, right? You give an infusion once, and then you get 8 to 10 months of remission on average without maintenance. I think it's a step forward, but it's not a cure. So what I kind of wanted to highlight here is that even after people relapse, there's still options. So in this single center study from Canada, you can see that there were many options given, and on average, people still lived 1.5 years even after CAR-T was given. So, and I hope this will only continue to get better, but it sort of tells you that even after CAR-T, there are options. And I'm going to highlight some of that here. So then, one of the CAR-T products, which all of you might have heard about, there's a lot of excitement and buzz, is called Silta Cell, right? So Silta Cell has been studied in a trial of about 113 patients, out of which 97 actually received Silta Cell. And you can see almost everybody responds. And these are people, as you can see in the table, heavily pretreated, right? 6 prior lines of treatment, refractory to multiple classes of drugs. About a quarter of them have high risk cytogenetics. And you can see that Silta Cell, as a single infusion, is working for most of them, for 98%. And unfortunately, again, people are relapsing, but the duration of response is better than what we have seen with ide-cel, which is what's approved right now. Again, the follow-up is short, but at 18 months, about 2/3 of patients had not yet progressed. All right. So I think that we're looking at close to 2 years of progression-free survival. So a single infusion leading to 2 years of remission is, for such heavily pretreated disease, it is a promising result. And we are designing clinical trials that are recruiting, and that's in Canada as well, I believe, where this is being studied earlier. And our hope is that once we study this drug earlier, we'll get even longer remissions, because the earlier, generally people tend to have longer remissions if drugs are used earlier as opposed to later in the disease course. So it's promising. We expect an approval in the United States by the end of the year. And I hope that there's less of a access difficulty, because with ide-cel, which is currently approved in the US, there's a lot of trouble getting patients to it. Most institutions have like one spot a month. So then we have a lot of patients with relapse refractory myeloma that need it. So I hope that the rollout is smoother and more patients can actually get this. So it's not, oops, sorry about that. So there are side effects. Most people have what's called cytokine release syndrome, where they get, it's like having a bad flu. Like they get fevers, and sometimes their blood pressure can drop. So that usually happens, but it's usually mild. Almost all of the cases, it was mild. And that's easy for us as patients to say. And I always catch myself because it's not my decision to say if a side effect is mild or not. But I think that most of the time it was tolerable, didn't lead to life-threatening side effects. And then the one thing that I think does need further attention is that there were some patients who developed like Parkinsonian type symptoms, like tremors and cognitive issues as well. It's a minority of patients, but as we start using this drug more and more and using it earlier in the disease course, I think those side effects become important and deserve further attention. So I think that's something that we're going to sort of watch out for. So all of these CAR Ts that I mentioned to you target a specific receptor called BCMA, all right? However, now we are moving beyond BCMA. So I think that, and that's a logical next step, right? Because unfortunately, patients are still relapsing even after they get BCMA CAR T. So now the new receptors have been identified, right? So this particular drug, talquetamab, targets GPRC5D, another receptor that's present on the plasma cells. So it's a very small study, and we don't have a lot of follow-up, but you can see that in about some heavily pretreated, 30 heavily pretreated patients, including some of which who had gotten prior BCMA therapy, we're seeing that 70% of them are responding, all right? And at 6 months, most of those patients have not yet progressed. So again, very preliminary, but I envision a future where, if BCMA doesn't work, then we'll have another target for which we can do bispecifics or CAR T. This is a bispecific, and just a refresher. So what a bispecific antibody is that, so think of it as two arms. One arm connects to the immune cell, the T cell, and the other arm connects to the myeloma cell, a specific receptor on the myeloma cell. So it sort of engages the immune system to the myeloma cell. So it's similar to CAR T, but the advantage of this is that, with CAR T, it takes a few weeks. So we collect the cells from our patients, and then we send them to the lab, and then, it takes time. But this is ready. So this is given off the shelf, just like any other drug. So I think bispecifics will have an increasingly prominent role in myeloma, and bispecifics targeting not just BCMA, but other targets is something that I think is very promising. And then I think that it's always important to sort of bring up the elephant in the room, and that's COVID vaccines. And I think that I'm sure you all have already discussed this with your myeloma doctors, that in general, patients with hematological malignancies, including myeloma, have suboptimal response to COVID vaccines. This graph is a little complicated, but you can see, generally speaking, that on the left, those red dots, and on the right are the blue dots. So the red dots represent myeloma patients, and the blue dot represents healthy controls. And about 220 patients in each arm were compared, and you can see that generally patients with myeloma developed less antibodies after a 2-dose vaccine strategy. So at least in my practice, and most of the guidelines would recommend this, that I do consider the third shot of the COVID vaccine to boost immunity. And I think that is something that it's fluid. I don't think we have like really high quality evidence, but I think that at least for patients with blood cancers, I would say that the benefits outweigh the risks. Even if we don't have conclusive, definitive evidence that this is going to protect you 100%, I think that I would take, whatever additional benefit that a third booster gets. And then again, this is also thought-provoking, not definitive by any means, but a really interesting study of about 34 patients from Sloan Kettering, New York City, where they looked at what sort of diet people had, and they looked at what sort of organisms, what sort of bacteria were present in the stool, and they found out that the health of the fecal microbiome. So if the fecal microbiome, which is an important thing, all of us have like millions of bacteria in us, but the bacteria of the gut, if they were more diverse, if they were healthier, that was associated with a higher chance of being MRD negative. All right, that's a very, very interesting, but it's far from definitive, right? They also found that the patients who had a higher plant-based diet tended to have higher rates of MRD negativity. But I think that, it's a very preliminary analysis. I'm not going to change my practice based on this. I'm not going to ask anybody to stop eating meat if that's something they really enjoy. I think it's important to eat healthy. And I think this is something that requires further research. And, perhaps modifying diet might lead to better outcomes, but I think that requires further research, because I think there are a lot of confounders and a lot of biases with this type of analysis. But it was definitely thought-provoking and an area for further research. So I definitely brought that up here. So that sort of covers, sums up the slides that I had. I wanted to, thank you all for listening today, and I wanted to obviously thank the incredible team that I'm a part of. But I would absolutely love to take any questions that you all might have.
All right, thank you, Dr. Mohyuddin, for the update from the IMW meeting that happened a few months ago. So I'm just gonna try to get the questions here. Let me open this up. So please do send in your questions as we go along, and I'll get to them. I'll try to get to all of them as much as we could in the time allotted. So we have until the end of the hour to finish this up. So let's start off with the master trial. So let's start. Well, we'll go in order with the way you presented things. So the master trial, you talked about MRD. So I noticed on one of the slides you kind of showed MRD -5 and MRD -6. Now, my understanding of MRD is -6 is a more sensitive way of -6 can find one myeloma cell in 1 million cells, and then -5 can find one myeloma cell in 100,000 cells. Why do we use MRD -5 and not -6? Is there?
Yeah, that's a great question. So thank you for bringing that up. So our technologies are continuing to get better and better. All right. So just having even if your MRD 10⁻⁻⁶, right, that still doesn't mean that you have 0 myeloma cells in your bone marrow. MRD 10⁻⁻⁶, as you mentioned, compared to 10⁻⁻⁵, or does imply that you have less myeloma cells, right? But we're currently limited by our technology in terms of how many myeloma cells we can detect. So I always explain this to people in terms of the iceberg analogy, right? So when you see an iceberg, there's a part of it that's protruding up, and then there's a huge part of it that's underneath the ocean surface. And our traditional criteria, such as light chains or the M protein, basically refer mostly to the area that's above the water, all right? But then with MRD, you start getting below the water. So with each sensitivity, right, so it used to be 10 raised to power minus 3, minus 4, minus 5. With each sensitivity, you are getting, better at detecting smaller and smaller quantities of myeloma cells. And I think that it's going to take a little bit of time for technology to sort of catch up to the trials. So if a trial started enrolling a few years ago and 10 raised to power minus 5 was the widespread method that was used at that time, we're going to get results from that. So that's going to be the definitive endpoint being used. But as our technologies evolve, we might start using more and more of these newer endpoints. And I think that also sort of raises the question that, does automatically going like escalating treatment, right, giving more and more chemo or other drugs to bring from 10 raised to power minus 5 to minus 6 in the future even more, like, does that automatically mean that people will live longer with our interventions? And I don't think anybody knows the answer to that question, right? And I think that's an area that is being investigated. But I think the short answer to your question is that it stems from what was mostly being used at the time the study started enrolling. And I think these things will continue to change, because the way MRD is right now, it is you need a bone marrow biopsy to measure it, which is invasive, which is cumbersome to our patients. So more and more, a lot of the updates from IMW actually refer to blood-based technologies to capture MRD. And that would be a big step forward, because I wouldn't have to get a bone marrow biopsy on my patients every 6 months just to sort of tell me whether they're MRD negative or not. So the technology is very fluid. It is going to adapt, and we'll continue to hopefully have more patient-centered, more comfortable ways of obtaining information on MRD.
Mm-hmm. Mm-hmm. So I guess in a way it also enables you to be able to compare a trial with another trial. If you're both using -5, then you can say, the people in this trial had a better response in this trial because they're using the same sensitivity. Is that also something that?
Right. So I always do those analyses in a very cautious way. So you're right that at least you're using the same depth of response. But I think these cross-trial comparisons are always very problematic. We all do them, all right? Like everybody compares DKRD to DVRD, right? And they compare MRD negativity rates. But I think what's important to note is that the patient populations are often very heterogeneous. So small differences in age or in the number of people who have high risk abnormalities, small differences in these can tip the MRD negativity rates one way or another. So we have a trial that's actually opening up. I think it's actually open in the US right now. That is actually a randomized trial of 3 different regimens: VRD, so Velcade Revlimid dexamethasone; KRD, which is carfilzomib Revlimid dexamethasone; and DARA carfilzomib Revlimid dexamethasone. So DKRD, KRD, and VRD. I think that's going to be the first time ever in a randomized study with an endpoint of MRD negativity that we're going to be able to compare 3 different regimens. Because up until now, we just compare across trials. We don't compare within trials.
Mm-hmm. Mm-hmm. Yeah, that's definitely better than comparing across trials.
Right.
So let's just stick for another question. Let's stick with a little bit with MRD. So you said we don't really know that if you have a better response, so better MRD, that the person will live longer in the end, right? Do we have any indication that perhaps like a standard risk patient, for example, who reaches MRD versus a high risk patient who reaches MRD, which would do better?
Right. So there is an important clarification that I want to make. I think this is a very important concept for us to understand, and it's a difficult concept for us to understand as well. So what I had said is that we don't know if escalating treatment to achieve MRD negativity, whether that translates into a longer survival or not. What I mean to say is that you have a patient who undergoes a treatment and they're MRD positive at the end of it. They've responded, organs are looking good, they're feeling better, but they're technically MRD positive. What we don't know is if I give escalated treatment at this point in time, whether it's going to make people live longer or not. all right? And trials are looking to answer that question. But what we do know is that if I give the same type of treatment, all right, so let's say 2 people, or I guess let's say, we give it to 200 people, and 100 people achieve MRD, the same treatment, right? 100 people achieve MRD negativity and 100 people don't, all right? What we do know generally is that people who do achieve MRD negativity generally tend to have longer responses and live longer compared to patients who don't achieve MRD negativity. So that's an important differentiation, right? Because whether or not you achieve MRD negativity depends not only on the type of treatment you're getting, but also what sort of disease biology you had, right? Because if you have high risk disease, then you're less likely to achieve MRD negativity, regardless of whatever treatment I gave you. So this sort of goes into the same concept where we know that MRD negativity is a good thing for people who achieve it, but what we don't know is adapting or altering treatment in an effort to achieve MRD negativity, whether that leads to better outcomes or not. It may very well, or it may not. And I think time will tell. But I think that's a very key and very difficult to understand concept that I kind of wanted to emphasize today.
Thank you. Thank you. You mentioned very briefly before bone marrow biopsies and liquid biopsies or blood biopsies as an alternative in the future. So is there research going on in there? Are these things in development? Are they close? Are they far? Like what can you tell us about liquid biopsies?
Yeah, that's a fantastic question. So I think they're close, and I think that they are increasingly going to be utilized in clinical trials within a year or two. I think within our daily practice, it might be there. I think they're at least a few years out. But basically, what we're looking at is a concept called, circulating tumor DNA, and that's one approach. And there's several approaches, but circulating tumor DNA means that all of these tumors that patients with myeloma have, whether it's in the bone marrow or whether it's a plasmacytoma somewhere else, some small DNA fragments from that tumor do get released into the bloodstream. So technology to sort of capture that is where the field is heading, and that it already is used for some solid cancers. So people with colon cancer, that the colon cancer releases some DNA, and that DNA can be picked up in a blood test. So I think the myeloma field is also looking at that technology. The other thing is that we are developing more and more sensitive methods to quantify the M protein. So the M protein, as you know, is made by those abnormal plasma cells, and our technology is getting better at recognizing smaller and smaller and smaller amounts of the M protein. This has important implications in how many people we diagnose with MGUS, for example, but it also has important implications for our patients with myeloma and for assessing their disease response. Because generally nowadays we define responses, based on whether the M protein is gone or not. But I think that will adapt as we get better at detecting smaller and smaller and smaller quantities of M protein.
Great, thank you so much. So lastly, with the master trial, this trial had a component of transplant in it, and you did mention during the presentation that absolutely there is still a role today for transplant. Do you think that will be the case in the future? Do you think CAR-T, for example, can replace that in the future? What are your thoughts on transplant as a standard of care?
That's a fantastic question. So I think that it is an open question in the field whether if someone achieves MRD negativity after 4 to 6 cycles of this modern quad therapy, do they need a transplant or not? I don't think anybody knows the answer to that question. And I think that different trials are looking at this differently, right? So in the master trial, these people went on to transplant. But in some of these other trials, people have had the option to forego a transplant if they've achieved MRD negativity with 4 cycles of a novel quad or 6 cycles of a novel quad. I think that we have trials that are being designed. So there's a French trial called the MIDAS, MIDAS trial. So that actually will help answer this question, because in that trial, patients who are MRD negative will either be randomized to a transplant or not. So I think we'll get an answer from that. I do think that CAR-T is being moved forward. I think the bar is high. I think that a CAR T has to have prolonged remissions in order to sort of replace transplant. I do think studies are being planned where CAR T is going to be compared head to head with transplant. There's a study that's currently open in the United States, but that is it's not comparing against transplant. So it's newly diagnosed disease, but it's being compared to, VRD followed by, just RD, as opposed to VRD followed by a transplant. So I think that that trial may very well be positive, but it doesn't really tell me that this replaces transplant. So I think we'll have to wait a while for that before we can broadly say that we're moving away from transplant. I think we just have to wait on the results from some of the studies that are pending. I do think it's an open question that if you have really deep responses, MRD negativity with your initial therapy, do you need a transplant or not? I don't think anybody has the answer. And I try to discuss this with my patients. I discuss the uncertainty. And on a case-by-case basis, I think we make that decision. But by and large, today, the standard of care remains a transplant for eligible patients. And I think for at least a few years it will, until we get some more data and we revisit this question.
Great, thank you. And I think that's a good segue to talk a little bit more about CAR T. So you talked to us about two types of CAR T. That one of them is FDA approved and one of them is not yet FDA approved. Now, when I first heard of CAR T cell therapies a few years ago, the big thing was, these CAR T cells that you inject back into the body, they sit there, they do their work, but then after a while they kind of disappear, right? So in a sense, in order to be able to compare CAR T to transplant, does that technology need to continue to evolve as well in order to kind of compare apples to apples?
That's a fantastic question. And I think the technology is evolving, right? So the newer products that we're seeing are better in terms of, deeper responses and durable responses compared to older products. So what we're seeing right now is the first wave of, products that have made it this far. And this technology will evolve. Undoubtedly it will evolve. I don't think that even Silta Cell represents the final, CAR T product that we're going to see. There are so many different strategies that are currently being studied in a way with the intention to optimize safety and efficacy. So whether that means, targeting multiple receptors, or whether that means, using supportive medications earlier rather than waiting for toxicity to happen and then use supportive medications. There's so many different strategies that are currently being studied, and CAR T will continue to get better. I do think that CAR T faces a very serious competition from bispecific antibodies, which I mentioned in my presentation. And the biggest advantage of bispecifics is that they're available like off the shelf. So you don't have to wait a few weeks to get it. And I think that's one of the problems I face every time I give a patient CAR T, is that they have to wait for a few weeks. And sometimes the disease is so unstable, you can't really afford to wait a few weeks. There are situations where, people get an infection or people disease progress, or sometimes even people die. Like, it's just that wait is, it's not ideal. And we're going to try to make that wait shorter, but bispecifics have this big practical advantage because once they're available commercially, right? So once they're approved, it'll be as easy as prescribing Velcade, right? Like, obviously there'll be some teaching involved, and physicians and nurses and patients have to get used to the side effects, but it'll be a lot more easier to give. So I think that is one of the biggest issues that CAR T faces. And we're seeing that with the rollout of the current CAR T products in the United States, that there are long wait lists at all these institutions, and people who need it cannot get it because the rollout and the manufacturing process and the companies, so they're just burdened and they're slow, and it's not efficient enough for our patients.
Mm-hmm. So, I mean, I hear what you're saying about the bispecifics, but one of I guess I'm going to call it a selling point, or one of the key things that a lot of patients are really interested in when it comes to the CAR T is that period of being treatment free. Now, when you're going to bispecifics, that's a continuous type of regimen. So, I mean, I did hear that there is a CAR T in development that is off the shelf, where it doesn't use your own cells. Is that still happening? Is that do you have any update on that kind of research? Did it fail? Is it still ongoing? What's happening with that kind?
So that's a great question. So we do have some very early preliminary results from that trial that were presented at ASH, and the results are promising. I think that technology is lagging behind using autologous or the patient's own cells. I do think it will catch up. I do think that there have been some recent, developments where, the recently FDA put a hold on one of these trials because, some changes in the genes of the cells were found after somebody else's cells were infused, and that's all a learning curve. I don't think that this is is going to put this off forever, but I think that technology is going to take time to evolve. But you're absolutely right that when I talk about CAR T for patients, one of the things they're most excited about is the time away from all treatments, and that's a big advantage of CAR T. And I think that things will continue to get better, and we'll eventually find the right space for each of these products. But they're all still in their learning phases, and we're seeing some growing pains as a result.
Mm-hmm. Yeah, and I guess the other aspect to it is if you're not getting continuous treatment, then the side effects as well are not there, right? With every dose or with every infusion. So that's also got to weigh the pros and cons. But if CAR T can catch up to that, then that would be great.
Totally.
Or if there were no side effects, that would be great.
I wish. Hopefully.
Yeah. Then a lot of things would be better without side effects, of course. Someone's asking, what was the 3-regimen trial that you mentioned for newly diagnosed? That was the MAIA trial, correct?
MAIA, MAIA.
MAIA. Okay, so let's move on to the next question. So I think we talked enough about CAR T. Let's talk about maybe I'm confusing my trials, but there was one of the trials. I don't think you talked about it, but compared maintenance therapy with DARA compared to maintenance with lenalidomide.
So there's a trial that's currently ongoing that's going to compare maintenance after a transplant with daratumumab and Revlimid versus Revlimid alone. To the best of my knowledge, there is no trial that's comparing daratumumab by itself as maintenance compared to Revlimid as maintenance. What we have gotten updates from is the Cassiopeia study, which is a study for patients with newly diagnosed myeloma that were transplant eligible, and this happened mostly in Europe, so where they use thalidomide, and we don't use thalidomide in the US, but a combination of Velcade, thalidomide, and dexamethasone, so VTD, was compared to daratumumab plus VTD. All right, so VTD versus Dara VTD, and then patients went on to a transplant, and after transplant there was another randomization where patients either got daratumumab as maintenance or they got nothing. They were just observed as maintenance. So perhaps that might be what you're referring to. And I think the results of this trial are very interesting and have a lot of implications for patients even in US and Canada, because what we learned from that trial is that obviously, DARA VTD versus VTD, you had better responses, more prolonged responses with DARA VTD. But the interesting thing is that if people got daratumumab during induction, so if they got it early in their disease course, they did not benefit by continuously getting daratumumab afterwards as maintenance. Or in other words, the only patients who benefited from getting a daratumumab maintenance were people who had not gotten daratumumab earlier in their disease course. But sort of tells us that, maybe giving daratumumab continuously for years upon years upon years is unnecessary. And I think that this calls for further trials. But that's sort of the Cassiopeia study. I do think it would be really good for us to know whether daratumumab by itself is better than lenalidomide by itself as maintenance, because there's some practical advantages to daratumumab, right? You get it once a month. In one of these trials, it was given once every 2 months, and you're not taking a pill daily. And daratumumab doesn't cause rashes and diarrhea the way that Revlimid does. So, I mean, I think it's a fair question to ask, but I don't know if there's a trial that's specifically looking at just Dara versus just Revlimid.
Yeah, thank you. Thanks for that clarification. Yeah, I remember seeing something about it, but anyways, we talked about the you talked about the Ocean trial and the failure of one of the how the control group did better than the experimental group. When it came to people with prior transplant. Now, my understanding is that melflufen is like a newer generation of melphalan, which is used during transplants. So, is there something going on there between kind of like someone who's been exposed to melphalan before versus and getting this drug, and are they looking at perhaps using this as a replacement for melphalan in the transplant setting?
That's a great question. So melflufen, basically, they've changed melphalan slightly. So they've, slightly modified the composition. And in preclinical studies, so in mice and in cell lines, melflufen is a lot more effective than melphalan because of the modification that's done. It sort of like focuses on the plasma cells, at least in the lab. All right. So, and it also in the lab, it worked in myeloma cells that melphalan didn't work anymore. All right, so that was the premise. The science behind it was interesting and deserved further attention. And I think that this trial showed that melflufen, despite all of the basic science behind it, it is still very, very toxic. It still causes low blood counts, and in patients who had a prior transplant, it just led to more deaths and wasn't safe. So it sort of tells us that at least in the lab, it's better than oral melphalan, right, which is what we use, or high dose IV melphalan. But I think that its use in the clinic has to be defined by more studies. I think that where I see this going is so the FDA has a meeting on October 28th in which they're actually going to decide what to do with melflufen and future trial design. So the FDA might ask for future trials. So we might see a trial specifically for people who have not gotten a transplant where melflufen is used and compared to something else. And I do think the company, if I were, if I owned the company, I would probably think about, designing trials, using this in high doses and seeing if it's safer than melphalan, because melphalan does cause a lot of toxicities, as I'm sure some of the people here can relate to. We don't know. It may be safer, it may not be safer, but I think it just deserves further attention. And I don't think that as of right now, I'd use it outside of the clinical study.
Well, we're very impatient. We want to know right away, but we have to wait for the results.
Exactly.
We have a question here going back to maintenance, and I think this is a good because I got this question very recently from someone that contacted me, and maybe we could hear your insights on this. So when we talk about Revlimid maintenance or lenalidomide maintenance, sorry. Doing it continuously. I know that some physicians will, for example, use it up to 2 years and then stop, or a certain amount of time and then stop. So the idea is to save it as a future treatment regimen, not to relapse while being on the maintenance treatment. So what can you tell to us about that? Do we know if it's better to use it for 2 years and stop, or just use it continuously? And also in terms of keeping that future treatment option open. So putting everything together, what would you say would be your recommendation?
That's a fantastic question. And I think that I don't know if there's a clear answer. I'm going to tell you what my recommendation is. But if you look back, like if you look at the studies that we have so far, people that stay on Revlimid maintenance for a longer period of time tend to have their disease stay under control for longer. all right? So generally, the longer you are on Revlimid, the longer your remission is. But it's a flawed way of looking at it, right? Because we're looking back and we're comparing people who were able to stay on Revlimid, their disease didn't progress. They were able to stay on Revlimid, and we're comparing it to people who were unable to stay on Revlimid for whatever reason. Maybe they couldn't handle it, or maybe they had disease progression. So it's not a fair comparison, all right? But if you look at study after study, generally, the longer people stay on Revlimid, the longer their remission is, all right? So I think that how I approach this, and then the other thing to consider is MRD might change the game, right? So we have trials that are enrolling right now where after 2 years, if people are MRD negative, they're taken off maintenance and watched, or they're randomized to continue treatment. So we'll know the answer in a few years. It'll take time. But as of right now, today, without results of MRD, if somebody is tolerating Revlimid fine, and if it's not affecting their quality of life, I generally prefer to keep it. And I think that you make a good point about keeping that as an option down the road. But the truth is that there are many other options available as well, right? So you have POM, you have carfilzomib, you have daratumumab, you're going to have CAR-T by the time people relapse a second, third time, or if they relapse a second, third time. You're going to have bispecifics. So I think that the withholding argument, for later argument, like, it holds less water in my opinion. So there's no clear answer. I think there's a lot of cultural difference. So like, I think in Europe, people stick to limited treatment. In US, people keep it for as long. I think it also stems to, reimbursement decisions and the cost and all of those factors. So there's no clear winner, but my preference generally is to keep people on it for as long as they can, as long as they're tolerating it okay.
Okay. So when it comes to maintenance therapy, right, and we're talking about future option, and keeping that as a future option, if you could maybe just remind us, maintenance therapy, does that show, has that shown to have a better PFS or better OS, or both?
That's a fantastic question. So the only drug that has shown an overall survival advantage when used in maintenance is Revlimid. All right. Now, there are other drugs that have shown a progression-free survival advantage, and so that includes ixazomib or Ninlaro, and that now also includes daratumumab based on the recent trial that I just explained to you all, the Cassiopeia trial. But when you're using a drug for maintenance, philosophically, how I think about it is you're subjecting people with very little evidence of disease, who are not having a lot of symptoms from the disease, to a treatment that's going to cause side effects. So in my mind, it has to do more than just delay remission. It has to make people live longer and better. And Revlimid has been shown to do that, but the other drugs have not yet, which is why Revlimid is our agent of choice for this setting.
Cool, thank you. So one more question we got here. You mentioned a trial comparing VRD to KRD to DARA KRD. Did I misunderstand?
Yes, no, that is a correct study. It's called the ADVANCE trial.
ADVANCE trial. Okay, and that's ongoing. It's just started.
Yeah, it just started, and it's in the US. But yeah, that'll tell us which of these three regimens has a higher MRD negativity rate.
Yeah, that's the one. Okay. Thank you. So I guess right before I let you go, I'm going to ask you one last question. Since you finished off your presentation about suboptimal response of COVID vaccines, maybe you could talk to us about what we know so far about the patient profile, or the types of treatments patients are on that would result in a suboptimal response, and perhaps strategies with dosing and maybe delaying in order to get the vaccine in and give it the best chance to work?
That's a great question. So based on the data that we have, and this is, again, it's not large patient samples, it's not really high quality data, but we have to make do with what we have. So in particular, patients receiving anti-CD38 therapies, so that's daratumumab and isatuximab, or patients receiving belantamab, the anti-BCMA. So those are the situations where we've seen the least responses to the COVID vaccine. So I'm not, by no means am I saying stop using daratumumab. I think it's a highly effective drug, but I think that this sort of brings into question, the art of medicine and doing things, adapting things for each unique individual. So let's say if, you were started on daratumumab based triplet and you've gotten a good response, you're 2-3 cycles in. I think that, what I do in those situations is that I'd probably hold daratumumab for, a few weeks and then give the COVID vaccine, give a few weeks for the antibodies to form, and then, you can restart treatment. I think that there's no right way of doing this, and different guidelines and different people will do this the right way. And I think that for somebody who's newly diagnosed, like, you may not want to hold treatment right away, right? You might want to get them the disease control they need. But in general, holding daratumumab for a little while, getting those antibodies to form, and then restarting, or in some situations, maybe just even holding it all together, may be the right decision. But I do think a third shot needs to be considered strongly. And I think that, we might have to be creative. Like for my patients, if they've gotten to Moderna, even though technically a third Pfizer is approved, but a third Moderna isn't, I think that, you can make a case that these patients, patients with cancer and a suppressed immune system, they benefit. So if you have 2 Moderna, you should maybe get a third Moderna. Or if you've had, one AstraZeneca, we should follow that up with an mRNA vaccine, and then maybe another mRNA vaccine, a few months later. So nobody knows the right answers, but we all know that 2 vaccines in patients with myeloma don't really give as good protection as they give to patients without myeloma. So nobody knows what the ideal solution is, but we have some solutions which we think might help, and I think it's worth utilizing them.
Thank you. Since we're on the topic, if I could just ask you one more question for one, if that's okay. There was, I'm not sure everybody, well, I'm pretty sure everybody on the line here heard of the death of Colin Powell, who was a myeloma patient. Was it yesterday or the day before? Things go so fast that I forget. But there's a lot of misinformation and disinformation about vaccines, and maybe if you just want to give a small comment on that situation.
Yeah, I think it's very unfortunate that he died, and it's also very unfortunate that his death has been used by some people in the media and on social media to sort of say that vaccines are inadequate, because that's not what this is about, right? So Colin Powell was an elderly gentleman with myeloma, right? So he was extremely high risk, and he had gotten his 2 shots, and we know that these 2 shots in people with blood cancers don't protect you 100%. And that's why we're having this entire conversation, and that's why we're thinking about a third dose strategy. So to use his case and to say that vaccines don't work is very, very unfortunate. And I think that the vaccines do work. I think even for our patients with cancer, they offer some protection. It's much better than no protection at all. I've had many patients with myeloma who have had vaccines, who've done well who've gotten COVID and who've made it out. And I don't know, maybe they wouldn't have made it out if they didn't have vaccines. So I think that they're well tolerated. They're now given to billions of people across the world, and they do offer protection. They may not offer 100% protection, but it's much better than the alternative for our patients with cancer.
And with that, thank you so much for taking the time this afternoon with us today to answer all our questions and to give us a research update. For those that don't know, Dr. Mohyuddin is on Twitter, so if you want to give him a follow, it's a good way to keep up to date with he likes to tweet from what I can see, and he has a lot of opinions, and it's really great to see, and it's a good way to learn a little bit more about what's happening in myeloma. So thanks a lot for that, and I wish you a great rest of the day.
Thank you so much. Have a good day.
You too. Have a good night. Bye.